بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد النبي الأمي وعلى آله وصحبه وسلم. It is really a pleasure and honor to stand among you, and thanks Dr. Azza for introduction. Thanks for organization of such fruitful conference. الحقيقة يعني قبل ما اتكلم عن المحاضرة بتاعتي أحب إن أنا أقول إن liver involvement in Gaucher disease is rare. معظم الكيسز اللي reported to have advanced liver disease can prior to the enzyme replacement therapy. والenzyme replacement therapy has changed the natural history of the disease, has changed the life of the patients. liver disease كان بيبقى أكتر في الحالات اللي عندها عاملة splenectomy prior to institution of liver of enzyme replacement therapy. هم دول الحالات اللي كان بيبقى فيهم burden of liver disease. Otherwise, it is a rare entity, a rare instance to have a case with Gaucher disease under enzyme replacement therapy with advanced liver disease. This is my disclosure, and today we are going to present a 1.5-year-old infant. He started to present to us at the age of 1.5 years. He is currently 18.5 years. There is positive consanguinity first cousin parents and progressive abdominal enlargement noticed in the first year of life, and significant pallor and recurrent blood transfusion, gross filtering with weight, height, and head circumference below the 5th percentile. There was no significant lymph nodes enlargement, scattered berboric spots and ecchymotic patches on the extremities. Initially normal neurologic examination and marked splenomegaly and mild hepatomegaly. This is what we all know, a review of the spectrum of the etiologies for splenomegaly. It could be infectious like Epstein-Barr virus, CMV, Bartonella, Brucella, typhus, hematologic disorders like hemolytic anemia, hemoglobin defects, autoimmune mechanisms, infiltrative diseases like leukemia, lymphoma, and storage diseases, hyperplasia of splenic monocytes, macrophage system like sarcoidosis, congestive splenomegaly like cases of portal hypertension and portal vein thrombosis, immunologic disorders like systemic lupus, rheumatoid, Wagner granulomatosis, autoimmune lymphoproliferative disorders, HLH, and Langerhans cells histocytosis. So we started some investigations, the basic investigations, and try to rule out some of these possibilities. CBC showed bicytopenia, hemoglobin of 8.3 grams and platelet 64, and the blood film showed normocytic normochromic anemia and thrombocytopenia with no detected abnormal cells. ESR first hour 10 millimeter and second hour 25. LDH triglyceride fibrinogen normal, so it is not likely to be HLH. Hemoglobin electrophoresis normal, so it is not likely to be thalassemia or hemoglobinopathies. Liver function was pretty normal, and ultrasound of the liver homogeneous with no dilatation or of portal vein or impaired velocity of portal blood flow. Epstein-Barr, cytomegalovirus, and HIV negative. So none of the infective possibilities, the hemolytic anemias, the malignancies is rather wise far possibility. And this is the abdominal ultrasound showing enlarged homogeneous liver, no focal lesion, patent normal portal vein, and hepatobetal flow, normal gallbladder, and huge splenomegaly. So we are still in a puzzle, and we need further investigations. Could you suggest further investigations? If you have finished, you can show us the results. Or the floor can suggest bone marrow biopsy enzymatic assay for storage disease. Actually, your suggestion was true. Both of the possibilities have been done simultaneously. We have obtained bone marrow, marked hypercellular bone marrow with no infiltration by abnormal cells. And in anticipation, we do always have to follow our clinical sense and to re-audit the investigations, and do not believe that the investigation is something that is holy and it is truly, really true, really true. And the beta cerebroglucosidase was at the lower limit of normal, 1.2. The lower limit of normal is 1. And also chitotriosidase is normal. Chitotriosidase is one of the biomarkers of lysosomal storage diseases. It is not specific for Gaucher disease. It is increased with many of other lysosomal storage diseases. So we are still in a puzzle. We hadn't reached a diagnosis. The bone marrow does not tell us anything except hypercellular. That means that there is almost a peripheral destruction. This enzymatic assay does not help us to diagnose or to point out a storage disease. And the patient is continue to suffer repeated blood transfusion every 2 weeks. Acute picture of splenic infarction, acute abdomen and picture of splenic infarction. And splenectomy was decided at the age of 1 year and 8 months. And astonishingly, the splenic biopsy showed sheets of Gaucher cells. We had been obliged in this patient to splenectomize the patient prior to definite diagnosis. And this is really something that we do not happy with. You will be never to be happy with splenectomizing a patient without a prior diagnosis unless you are obliged, like in such a situation, you have exhausted your investigation, you have performed the bone marrow, you have performed the enzymatic assay, ruled out malignancies and the infections, and the patient is deteriorating. And unfortunately, the bone marrow results showed hypercellularity, pointing to a peripheral destruction. So we are confronted with a patient that's showing anemia, thrombocytopenia, splenomegaly, and sheets of Gaucher cells in the spleen. And you have no lab evidence of Gaucher cells. What might be the diagnosis? How we can solve this puzzle? We think in 2 ways. The first way, either our investigation had been misleading, there is something wrong with the investigation, or there is other explanation. The other explanation is a rare form of Gaucher disease resulting from saposin C deficiency. Saposin C is a cofactor for the enzyme, a protein cofactor, and there are deletion or genetic mutation in the saposin C coding gene, resulting in ineffective action of the beta cerebroglucosidase enzyme, the same manifestation of Gaucher cells, but with normal enzymatic activity. The defect is the enzyme cofactor. This is possibility number 1. And the other possibility that we have something wrong in our investigation. So we decided to repeat the investigation once more. Here we insisted to take the enzymatic assay sample almost 3 to 4 weeks. It should be almost 1 month away from any blood transfusion, but the patient couldn't wait for 1 month without blood transfusion, so it was almost around 3 to 4 weeks. And we repeated the chito level. The enzymatic assay come at to be low, and we repeated the bone marrow aspirated, and it was infiltrated by non-hemobiotic cells, query Gaucher cells. So the investigation, the first run of investigation was misleading, and the patient is actually a patient with Gaucher disease, not saposin C deficiency. But here we have to solve this puzzle again. Why he is a patient with Gaucher disease and the chito level, the chito is a biomarker of Gaucher disease. It should be high in Gaucher disease. Again, there is some exceptions that chitotriosidase has variants. There is a mutations in the chitotriosidase gene leading to low expression of chito. So in some instances of Gaucher disease cases, there is low chito. The chito is not expressed. And our case was one of these cases that had low expression of chitotriosidase. And this had been reported in a patient in South Africa, and the chitotriosidase deficiency is common in non-African rather than African population, and it serves as a good biomarker in African, but in non-African population there is relatively a 20 to 50% range of 24 dB duplication, resulting in low expression of chitotriosidase. Coming back to our patient, this patient had progressive worsening of his condition with significant pallor purpura and ecchymosis and progressive liver enlargement. Patient with Gaucher disease, when is exposed to splenectomy prior to enzyme replacement therapy, are usually showing deterioration of the clinical picture. Because the spleen is like a trap that engulfs many macrophages, leading with the accumulated storage material. This macrophages has to be redistributed in every tissue, in the bone, sometimes in the liver, sometimes in the lung, leading to aggressive systemic manifestation of the disease. And the bone marrow aspirate that had been repeated showed infiltration with Gaucher disease. The enzymatic assay showed low enzyme. And on follow-up, the patient showed development of neurologic symptoms. At the age of almost around 7 to 10 years, he started to develop neurologic manifestation. So he is a case of type 3 Gaucher disease. And he started enzyme replacement therapy on the age of 2.5 years on the dose of 60 units per kg every 2 weeks. And also later on, the diagnosis had been confirmed when it was available by gene mutation. It is L44B homozygous. And the mother had a younger brother. And this younger brother is a Gaucher disease with the same chito level owing to low expression of chito in the family. This is his follow-up growth curves. He never achieved a good growth catch-up because of, I think, because of his splenectomy. The height is also, he never achieved a catch-up of height because of splenectomy. In addition that he had developed marked bone disease resulting in pathologic fracture of the left femur neck and orthopedic intervention with internal fixation. His current weight is 40 and the height 150 below the 5th percentile. His standard staging is pubertal. He is 18 years old. He had no pulmonary manifestation. His cardiovascular system is okay. He had average size of organs with no hepatomegaly and splenectomized, of course, has no lymph nodes enlargement, and his hematologic parameters had been stable on enzyme replacement therapy within few months after institution of ERT. He started to have skeletal manifestation at the age of 7 years with fracture of right upper arm and fracture of left femur, and had orthopedic corrective surgery, internal fixation in 2013, resulting in short left leg and limbing. He had normal tone and reflexes, oculomotor apraxia, absent seizure, and generalized epileptogenic discharge in EEG, and atrophic changes in MRI, and he is maintained on valproic acids. This is his image, and you can see that he is limping. This is his wall. He is limping because of short left leg. And this is a skeletal survey, the last skeletal survey in this month, 2013, showing evidence of internal fixation of the left hip, shortened left lower limb, diffuse decreased bone density of all scanned bones, and thickening of the cortex of the medial side of the shaft of the left tibia. This is the internal fixation of the left femur neck, and this is the softening and rarefaction of the medial aspect of left tibia, and this is the Erlenmeyer deformity, the flask-shaped deformity of the lower femur. And his bone density, the DEXA scan is minus 2.5. He is maintained on calcium and vitamin D supplementation. And the neurologic manifestation, he is type 3, as we mentioned, with oculomotor apraxia and absent seizures, epileptogenic activity, and atrophic changes in the MRI. This is his last lab. The CBC is normalized, liver function is okay, creatinine is normal, ESR, CRB, lipid profile is normal, and his lyso here is a very useful biomarker because his Chi2 level is normal. We cannot use Chi2 anymore in the follow-up of this patient. But lyso is a specific and sensitive biomarker. He is high for, the normal is around 14. His Chi2 is high because of poor response to ERT because of the previous splenectomy. The follow-up of hemoglobin, he is having a steady hemoglobin with no transfusion, normal platelet count with no bleeding tendencies, and sometimes there is some thrombocytosis owing to the splenectomy. The liver span is steady in spite of achieving age. It is constant since the age of 2 years till the age of 18 years. And this is the last abdominal ultrasound showing that the liver is 15 centimeter with homogeneous echo pattern. So, patient with splenomegaly and thrombocytopenia should be tested for Gaucher disease when the following conditions have been ruled out. If you have ruled hematologic malignancies, hemolytic anemias, especially thalassemia, immune thrombocytopenia, immune thrombocytopenic purpura, and splenomegaly due to portal hypertension, if you have ruled these possibilities, you have to screen for Gaucher disease. Also, patients with splenomegaly and or thrombocytopenia should be tested for Gaucher disease when these diagnoses are present: idiopathic splenomegaly with no known cause, or idiopathic thrombocytopenia with no known cause, or atypical or unresponsive idiopathic thrombocytopenia, or unexplained bleeding and bruising, or unexplained hyperferritinemia with normal transferrin saturation. And this algorithm is for diagnosis of splenomegaly and thrombocytopenia. Just I want you to remember that there are some signs when it is present: gross deceleration or retardation, Erlenmeyer-Flask deformity, strabismus or oculomotor apraxia, increased level of ferritin or acid phosphatase level. In presence of these 4 criteria, any of these 4 criteria is a guarantee to have enzyme assay first, even prior to moving through exclusion of other causes and having the bone marrow. So splenectomy should be avoided whenever it is possible, and you should try to reach the primary diagnosis first before removing the spleen. Splenectomy is one of the dangerous maneuvers, especially in patients with Gaucher cells, with Gaucher disease, that can lead to adverse factors and worsening of the disease condition. Chi2 is a useful biomarker, but remember that some cases with Gaucher disease have low expression of Chi2. In such instance, the lyso-GB1 will be a better marker for monitoring of the disease. And finally, subposin C deficiency can result in similar clinical picture of Gaucher disease in spite of normal enzymatic assay. Thank you, and any questions welcome. Thank you.